talking today about type 2 diabetes, glycemic targets, non-insulin therapies, and bedtime insulin, daytime orals, also called BIDO protocol. Dr. Davidson was a former director of the American Diabetes Association, president of the American Diabetes Association, one of the world's top diabetologists, and it's a delight to have him here today talking about diabetes protocols. Thank you, Dr. Davidson.
Thank you, Dr. Friedman. The county has put together a diabetes expert panel which has officially agreed on some protocols that we are rolling out for the care of diabetic patients in the county system. I should say that these protocols are a result of a consensus in a committee, and as such, no one is really always happy with what comes out of the committee, but we agree on the compromises. A few that I think we need to discuss and maybe point out a little difference about them, and in those few I will give you my own views. But in general, this is the consensus of the diabetes expert panel. All right, Dr. Friedman, so far, how do I do it? So all right, so I have no conflicts of interest for this presentation. So the first protocol is the glycemic targets. And of course, targets can change over time with advancing age and other parameters. And so the provider is directed to discuss the goals with the patient. And if the goals that I'm going to talk about in just a minute are not what the provider is going to have the patient do, then the provider needs to put into the medical record of why there be a change. And of course, poor glycemic control is often due to a variety of reasons, and in our population, non-compliance is a large part of it, but there's also under-treatment and over-treatment. It's important, of course, to consider the patient's attitudes and cultural beliefs, and that needs to be taken into consideration. And if there's any difficulty in maintaining good glycemic control, then we ask you all to consider e-consults. Now, in young patients who have no significant comorbidities and only have occasional or no hypoglycemia, then one might consider an A1C goal of less than 6.5%. But in general, most patients with diabetes, the A1C goal should be less than 7%. And there is very good evidence for this. Probably the best evidence comes from a type 1 diabetic landmark study called the DCCT. And this was a study that occurred over 6 years. And you can see that on this slide, the average A1C over those 6 years, which is down here on the x-axis, is plotted against the relative risk of the microvascular complications of diabetes. And if the A1C on average was less than 7%, there was almost no increase in the risk. And that's the reason that the less than 7% was agreed upon. Now that's in type 1 diabetics, and there are other studies to show the same thing. This is an observation study done at Joslin Clinic where they looked at the development of microalbuminuria. So these patients did not have microalbuminuria at the beginning. This was an old study, and so the hemoglobin A1Cs were done by a different method, and they were a little higher. But if you go down here, these are the current methods that are used, and you can see that if you stay below 7.2 and even below 8, there is almost no increase in the relative risk of getting microalbuminuria. The same institution did a study looking at the patients who had microalbuminuria. What was their chances of getting macro or clinical proteinuria? And again, you can see that if the A1C is kept below 7, there's almost no chance. A slight increase when you get toward 8, but over 8, it really takes off. This is a study that was done in type 2 patients requiring insulin, a smaller Japanese study done just like the DCCT one, and you get the same results. If the A1C over the course of this 6-year period was less than 7, no increase in the chances of getting retinopathy, nor in the chances of getting nephropathy. And finally, this study is done showing the cumulative incidence of patients who did not have microalbuminuria, but over 6 years, what was their chances of getting microalbuminuria. And you can see that below 7%, there was no chance whatsoever, only a very small chance between 7 and 8, and over 8, then the cumulative incidence really took off. So that's the reason why less than 7% is considered the goal of what we should be achieving. And it turns out, and this is in a type 2 study that was done over about an 18-year period, that every 1% lowering of the A1C, you actually decrease the relative risk of getting a microvascular complication by 37%. Again, more evidence that we need tight control. Now, having said that, though, let's go back. Let's go to situations where less than 7% might not be valid. And if I can find a pointer, could you take care of the calling the user? Okay.
No, it just comes up.
If the committee felt the committee felt that if the patient had a A1C that was close to target, and the next step was insulin, that a discussion would be held, and you would just keep them on that oral agent regimen and not go on to insulin. And therefore, the goal would be between 7.5 and 8%. And then there'd be a number of situations where you might want to make the control less tight. And advanced age is one, of course, cognitive dysfunction, the frail elderly, if comorbidities were especially a problem, and if social and educational issues were involved, that would be a reason to relax the control. Fertility, of course, a short life expectancy would be one reason. And the other ones would be advanced diabetic complications. If you have microvascular complications that are advanced, tight control is not going to make any difference. Patients with hypoglycemic unawareness, you're going to have to release your stringent control. The one that I disagreed with was a patient's duration of diabetes that is difficult to control. A lot of these patients have compliance issues, but if you continue to work with them, a significant number will eventually get on board. So I would not use this as an absolute reason to loosen one's control.
Dr. Davidson, if you have one diabetes complication, but not the other one, wouldn't tight control help you to prevent the other one?
Yes. So advanced complications would be advanced nephropathy plus retinopathy. Yes, good point. Now, this sometimes helps to convince patients. They don't really understand an A1C, although we all know it's an average glucose. But if you can tell them what their average glucose is, looking at their A1C, sometimes that motivates them. And so, for instance, if you're looking at an average A1C of, say, 8.5, down here at the bottom, that average over a 24-hour period of time is almost 200 milligrams per deciliter, and sometimes that convinces them that they should do something about it. Now, before we go on to the next protocol, I'm going to need to give you some pathophysiology of diabetes. The relationship between insulin secretion on the y-axis here, if I can find my pointer again. Thank you. The relationship between insulin secretion and insulin sensitivity is a hyperbolic curvilinear one. And the main factor that controls the insulin sensitivity that we have is a genetic one. In the normal population, there's about a 5- to 7-fold difference in the insulin sensitivity. So if you're born with a lot of insulin sensitivity, here we are, I found it. You don't need much insulin secretion to keep you on this curve, which means you don't get diabetes. If you're born with a lot of insulin resistance, you're going to need a lot more insulin. And as we age, especially as we get obese, we move up this curve and we need more and more insulin to keep us out of diabetes. If for some genetic reason we cannot keep up with that demand, we, quote, fall off the curve, unquote, and get type 2 diabetes. Now, the two ways to treat that, of course, is to increase insulin secretion or to increase insulin sensitivity so that the amount of insulin secretion we have will now be able to do the job much better. Unfortunately, insulin secretion is decreased at the time of diagnosis, and here you can see that it's about 50% down at the time of diagnosis, and it progressively decreases over time. And unfortunately, this occurs no matter how we treat the patient. With sulfonylurea agent, you get some increase, but note that the fall off of insulin secretion has the same curve as metformin does in the red, or diet alone treatment done in the yellow. It turns out at the moment there are 12 classes of drugs that treat type 2 diabetes. And on this slide, though, I have bolded the ones that the county covers, and I've underlined the ones that are now available in some of the health plans that our patients have. So the county, for instance, of course, has metformin and sulfonylureas and TZD, and in certain circumstances, a GLP-1 agonist, and of course, insulin. And underlying ones that the county plans may have outside of the county are just a new drug is called the SGLT2 inhibitors, which I'll talk about, and the DPP4 inhibitors, which we'll also talk about. I should say, however, that the county would like us to use only the medications that are dispensed at county pharmacies. And that's because these medicines are usually much cheaper there than the cost of these medications at outside pharmacies. And if they're picked up at an outside pharmacy, the county has to pay for that increased price instead of the lower price that they have negotiated. Having said that, I personally use the following 4 criteria to decide on a drug or a class of drugs. Most important is the effectiveness of the drug. The adverse or side effects, of course, is a very important component. The ease of adherence, injections being more difficult than oral agents. If you take injected insulin, you have to worry about hypoglycemia, and you have to measure your glucose, so that's a little different than an injected GLP-1, and the cost should be a factor in our considerations. In terms of effectiveness, there's been a lot of studies comparing all these various drugs. If you look at these are meta-analyses I'm going to show you on the next several slides, and these are randomized clinical trials that have looked at these drugs compared to placebo. And there's been over 60 of these studies and over 25,000 patients, and all of the drugs associated, all the drugs used in these studies were associated with similar A1C reductions, and you can see listed here the drugs that have been tested. If you look at the drugs that are added to patients on metformin, there's been 27 trials over 10,000 patients. Again, you can see the drugs that have been added and compared against each other, compared against placebo, but all the drugs were associated with a similar A1C reduction. In this slide, you have over 50 studies that have looked at adding these drugs to patients who have failed metformin plus the sulfonylurea, and again, over 20,000 patients, the A1C reductions have all been the same. There's a few studies where I got ahead of myself here. This slide shows you the studies that were added to metformin plus the sulfonylurea. The most important way to value these drugs is to compare them head-to-head. And that's done in this study, in this slide, over 50 studies, 20,000 patients, and all the drugs were equally efficacious, equally effective, except a few, the DPP4 inhibitors were not quite as effective as metformin, but some others, they were equally effective. So very quickly, let's go over some of the drugs that the county has on their formulary. Metformin, an old favorite, a lot of advantages you can see listed. I need to talk to you about the disadvantages. Of course, the adverse GI side effects are well known. The CI here is contraindications, and there's been a lot of controversy recently about these contraindications. It turns out that hepatic dysfunction is not a contraindication. Metformin does not affect liver function. The thought was that if you had liver dysfunction, you could not metabolize lactate, and you would have a chance to get lactic acidosis, but that turns out not to be the case. Recent studies and meta-analyses have shown that there is really not a very strong relationship between metformin and renal function. The thought was that since metformin is only excreted by the kidneys, that it would build up and cause lactic acidosis, but this has not been shown to be that true, and that will come into play when I talk about the county protocol. So the county protocol is the second one was using oral antidiabetic medications. In the first column here, this protocol will be the current strength that the patient is on. The second column will be the step up, how much we should increase the dose. The third column is the minimum time we should use before we step it up, and then there's comments in the last column. So the first recommended medication is metformin, unless it's contraindicated, and the step up, as you'll see here. So we start with 500 milligrams once a week, once a day, just for a week, and then you go on to the BID twice a day. The reason is that you gradually build up the doses, less likely to get GI side effects. You should take the metformin with meals because the GI side effects are less. If twice a day isn't working, you go up to 3 times a day, and if 3 times a day doesn't work, you go up to 4 times a day. So the maximum dose is 1,000 milligrams twice a day. You have to check the estimated glomerular filtration rate. If it's over 60, then you can go up to the maximal dose. In the wisdom of the committee, if it were between 45 and 60, you should not start it. But if they were on it and the eGFR went to between 45 and 60, you could keep them on a half max dose. To me, this doesn't make sense. If it's okay when they're on it, I don't see why we shouldn't start it. And there's guidelines in the literature that suggest we can use the half max dose between an eGFR of 45 and 60. You take it with the meals, as I said. If when you get a max dose and you're not in control, and the average, I should go back up here. The goal is to keep the average glucose, I can see it right here, above 140. So if it's above 140, we need to keep going up. If the average is under 140, then supposedly we're at the maximum dose, or at the appropriate dose. If we are not, we then need to go on to a sulfonylurea. And if the patient is at risk for hypoglycemia, then you want to use glipizide. If not, you want to use glymeparide according to the committee. You start with 2 milligrams, and if you again can't keep the average fasting plasma glucose below 140, then you go on to 4 milligrams, and you go from 4 milligrams to 8 milligrams. If you're going to use glipizide, you start at 5, then you go to 10, then they go to 10 to 15 to 15 to 10, 15 to 20, and down 20 to 40. That's about 5 or 6 steps. In our clinic, we usually go from 10 to 20 to 40. But the concept is the same. You keep increasing the dose to maximum until you get the glucose, fasting glucose, where you want it. If that doesn't work, then the third drug that's suggested in the county is TZD. And we all know that TZDs have some side effects. Very importantly, they have a slow onset of action. And so you don't usually see much of an effect for the first month. You don't get a really good effect until the second month. There's side effects of weight gain, increased fat accumulation. Very interestingly, the fat accumulation is around the outside of the body. And that causes weight gain, but does not cause increased insulin resistance. Increased insulin resistance is associated with accumulation of fat within the abdomen. And if anything, that fat store decreases under the influence of the TZD. Fluid retention is a side effect, heart failure, of course. If you give it for a long period of time, you can get decreased bone mineral density, and increased fractures have been associated with long-term use in both men and women. I've crossed out increased bladder cancer because there really is very little evidence of that, in spite of what you may hear on television by the plaintiff attorneys. There has been 20 studies that have looked at that, and the evidence is very weak, but patients are aware of that, and you need to bring that up when you discuss that with them. We have shown that TZDs are very effective. We have over 100 patients, as you can see on this slide, that when they have failed metformin and sulfonylurea, their average A1Cs have been over 9, and 4 months later, they have come down to an average of 7.5. And the reason for this is that insulin secretion now is, if anything, is getting less and less, but here we're increasing the insulin sensitivity so that the amount of insulin secretion that's available is very effective, and the patients can be controlled for periods of time on that third drug. The county's protocol is to start with 30 milligrams, and in 30 days, if you can tolerate it, and if your fasting glucose is greater than 140, then you go on to the maximal dose of 45. Since, as I've just told you, it doesn't work very effectively in the first month, most patients will end up on the maximal dose, and that's what we use in our clinic. If that doesn't work, then you have to go on to bedtime insulin. If the A1C is between 8 and 10% according to the protocol, but if the A1C is over 10%, you're asked to do e-consult and refer the patient to the diabetes specialist. Now, the county will let endocrinologists use BIDO or and the criteria are listed on this slide, but the GLP-1 agonists are available in LA Care and in some other insurance plans, so we need to discuss a little bit about the Incretin axis. Now, the Incretin axis is defined as follows. Here we have an oral glucose tolerance test done in normal people, and over here we have something called C-peptide, which is a reflection of insulin secretion. And the patients, or these subjects, were then given intravenous glucose in such a manner that they were able to get the same glucose levels as they did when they were given oral glucose, but look at the insulin secretion. It's much less. And the difference there is called the incretin effect. The incretin effect is due to several hormones that are released by the GI tract after we eat. And the one we're going to talk about is called GLP-1, or glucagon-like peptide 1. And after we eat, it is secreted by the intestine, goes into the blood, and it has its actions, which you can barely see here. However, it doesn't last long. There's an enzyme called DPP4, which degrades it, and the half-life of GLP-1 is only 2 minutes in the circulation, and the breakdown products are very inactive. So let's look at the incretin effect and see how it works in general. As I said, it's secreted when we eat. The beta cells respond to it by increasing insulin secretion. And very importantly, this is done in a glucose-dependent manner, which means if the glucose levels are high, the beta cells secrete insulin. But when the glucose levels get to normal and low, the insulin is not secreted, which means that the chances of hypoglycemia are minimized considerably. The other effect it has on the pancreas is it decreases glucagon from the pancreas. And that's very important because glucagon actually increases in diabetics, as I'll show you in a minute, as opposed to being suppressed. And of course, glucagon breaks down glycogen in the liver and causes hyperglycemia. Other effects it has, besides working beneficially on the liver, is it slows down the stomach emptying, and therefore it blunts the postprandial rise after eating. And finally, injectable GLP-1 agonists decrease satiety by reducing appetite in the central nervous system. So this slide shows you how it affects some of these parameters. The blue here are glucose tolerance tests in normal people, Glucose is good. Insulin levels go right up. And notice that glucagon gets suppressed. In the red is what happens when a diabetic population eats. The glucoses go very high. Insulin doesn't come out very much. And note that glucagon is not suppressed. And it turns out that even if we control patients on insulin, we cannot decrease glucagon after eating. So here's diabetic patients that eat. They get some glucose insulin rise, an increase in their glucagon. Here they're given insulin actually intravenously before eating, and you can see that the glucagon is not suppressed. So this is an important aspect of GLP-1 agonist activity. And back here in 1971, Dr. Unger postulated that if we could somehow suppress glucagon, it might be very helpful. And finally, 45 years later, it occurred. So the class of drugs of dipeptidyl peptidase inhibitors, DPP4 inhibitors, are available in some of LA Care. There's 3 of them: sitagliptin, saxagliptin, linagliptin. Their advantages: they have no hypoglycemia. They're taken orally, which is an advantage compared to the injectable GLP-1 agonists. They do not cause any weight gain, but they don't cause any weight loss. And so if these are available, one might consider using them instead of a sulfonylurea, because you don't get hypoglycemia from it and you don't get weight gain. So it could be used as a second-line drug, again, not through the county, only through the other insurance plans. Now, the glucagon-like peptide-1 agonists, there are several that are available. Exenatide or BIDO is taken twice a day, injectable, liraglutide or Victoza once a day. These are available in some of the plans. They now actually have once-a-week injectable GLP-1 agonists. The advantage of these is that the weight loss is very common with these drugs, and you do not get hypoglycemia. Disadvantage is you get nausea and sometimes vomiting in the first couple of weeks, but most often that wears off. Some thought about it may cause pancreatitis, but the latest studies have really not supported that, and they're unfortunately expensive. And the final class of drugs, which are very interesting and are available now at some of the health plans that our patients use, are called the SGLT2 inhibitors. That's the sodium glucose transporter inhibitors. Now, as you can remember from your first couple of years at medical school, all the glucose in the body is filtered through the kidneys. And here we have a cartoon where it goes through the glomerulus. And as you know, normally, no glucose ends up in the urine. And the reason that occurs is that as the fluid goes down through the tubule, proximal tubule, there's an enzyme called SGLT2, which reabsorbs the glucose back into the bloodstream. 90% of it occurs right here, and about 10% of it occurs further on with a related enzyme, SGLT1. We've now developed inhibitors of that enzyme, and the advantage of them is that they do not require insulin secretion. All of the other drugs that I've talked about that were not insulin require insulin secretion to work. So this is a niche for these drugs that is very unique. There's an added advantage is there's a small amount of weight loss, there's a small amount of blood pressure lowering. The disadvantages are, of course, that patients have urinary frequency because of urinating out all that glucose. And in some of the studies, there's a slight increase in urinary tract infections. A more serious side effect is that there's about a 2 or 3-fold increase in mycotic infections, fungal infections, in women, vulvovaginitis, and in men, balanitis, which is a fungus infection of the tip of the penis, and it's more common in uncircumcised penises. Just last month, a side effect of euglycemic DKA, diabetic ketoacidosis, was shown to occur in these patients. Now, some of these patients were using this drug and they were type 1s, and it's not indicated in those, but there were some type 2 patients who also got DKA, and the tricky part here is because the patients are losing so much glucose in the urine, the glucoses don't get high in the bloodstream, and therefore it's euglycemic ketoacidosis, and it's easy to miss this because you expect the glucoses to be high. Some of these drugs you can't use if the eGFR is below 45 or below 60. The other ones you can, and you need to see which specific ones you're using.
Excuse me,
now,
Mayor?
Called insulin, which happens to be very effective. Of course, the disadvantages are you have to do self-monitoring of blood glucose, there's hypoglycemia, there's weight gain. Patients need to have a relative consistency of lifestyle. But the third protocol that the county agreed on was something called BIDO, Bedtime Insulin Daytime Oral Agents. And let me show you the cartoon as to why this works. So
hey, Mayor, can you hear me?
Yeah.
I
can hear something.
Your camera's pointing up at the ceiling. Do you mind putting it towards the slides?
What's pointing at the pointer? Is it pointing toward the ceiling?
Yeah, the camera is pointing at the kind of above your forehead, pointing at the ceiling. I don't know if you can push it towards the slides. Thanks.
I don't know. My technical advisor here is trying to do this.
Can you see the screen?
A picture of your face.
Can you see his face?
Can you see the screen as well?
Just your face, that's all. That's fine, I can listen, no problem.
No. You need to see the slide. My face is important.
Sorry.
Yeah, you should be able to see the
slide.
slide.
So can you see the slide now?
No, it's just your face. That's fine. Don't worry about it.
Fine.
Can anyone else see the slide?
Is everyone else is not seeing any of these slides?
The slide's visible in the WebEx. Everything is visible, except that it is just the top of your head from the camera. That's true.
But you can see the slides, though, right?
No, no slides.
Yeah, I can see the slides, but that's on the WebEx.
Okay, I'll try fiddling.
No, it's working. It's okay.
Okay.
Don't worry, I got a good ear.
John, again, slide.
Okay. All right, so back to this cartoon. So the patients now are failing oral agents, and here's their fasting glucose, and here you can see their postprandial rise. We start bedtime insulin, often NPH, and increase it until we get the fasting glucoses in the target range. And in the green, if there's enough insulin secretion left, pills or the non-insulin medications will keep the patient under control. If not, there'll be a gradual increase during the day. And this actually happens. Study done, patients failing pills, and this is 270 fasting glucose. You can see the postprandial rise. They were given NPH insulin and actually stopped the oral agents. Fastings were brought down under 100, and you can see the postprandial rise is very similar to here. So the protocol is as follows. Now, there's actually two protocols. One is a simplified one, and one is a complex one, but this screen here applies to both of them. And it's called BIDO, Bedtime Insulin Daytime Oral Agents. And in the county's wisdom, we're supposed to use this when the glucoses, or the A1C is between 8 to 10%. You continue the sulfonylurea agent. If they're on both a sulfonylurea and a DPP-4 inhibitor, stop the DPP-4. And if they are not taking the sulfonylurea, you continue the DPP-4. They want us to reduce the pioglitazone down to 15 milligrams. And then the initial dose is based on the BMI. And I'll get to that in a minute. And then you use the fasting glucose to adjust the insulin doses. Check the fasting glucoses within 30 minutes of breakfast. You're looking for an average over the past week, supposedly, and you're trying to keep it between 100 and 140. If the patient has severe hypoglycemia, now severe hypoglycemia is defined as the patient needing help from a third party. Right. They should notify their provider immediately. If it's simply just hypoglycemia, then for mild hypoglycemia, get a hold of the provider within a week. Of course, if they have symptoms of hypoglycemia, you decrease the NPH dose. So the suggestion is to start NPH because it's about 1/10 as expensive in the county system as glargine. And if they're not at target, if they're not at target but they're getting hypoglycemia, then you could switch to glargine because you get less overnight hypoglycemia. The goal here supposedly is to keep the pre-breakfast SMBG to around 100 as close as possible. And then there is a stipulation here to have the pre-dinner glucose not more than 50 above the fasting. And that's something that I personally don't understand, but that's in the protocol. And they say if the gap is greater than 50 between the fasting and the pre-dinner one for 2 weeks in a row, then you have to intensify the insulin regimen. And that C below really is the next protocol, which we haven't finished yet. But once the SMBG is 100 to 140 for a month, then you go on to stage 2. So I'll get to stage 2 in a minute. Now, the initial dose depends on the BMI. If it's less than 30 and the fasting glucose is greater than 180, then you give 10 units. If the fasting glucose is less than 180, that first one was greater than, you give 0.1 unit per kilogram. If the BMI is over 30, here we are, then, and the FBG is greater than a 180, start with 15. If it's less than 180, you start with 0.15 units per kilogram. And then the step B, of course, is to instruct the patient how to use insulin and how to measure the glucoses and reinforce education, etc. So that's the starting dose. You obviously ask about hypoglycemia when you see the patient. And you adjust the insulin dose if more than 50% of the pre-breakfast SMBG values over the past week are greater than 140 or less, and if it's less than 100, according to the algorithm, wait a minute here, you adjust it, okay, that's adjusting it. So if more than 50 or over 140, you adjust it by going up. If more than 50% are under 100 or less than 100, then you go down. And then they say that if the target is not achieved after 6 months of dose adjustments, or this pre-dinner glucose is above the target, then you have to go on to intensification. Now, the important thing here is how do you adjust the dose? And this is the simplified version. If the glucose is less than 100 or you have symptoms of hypoglycemia, you decrease by 2 units. If it's between 100 and 140, then you don't change it. If it's greater than 140, you increase by 2 units. All this in patients who are less than 30. If their BMI is greater than 30, then you decrease it by 3 units and you increase it by 3 units. And every 3 months, you're supposed to check A1Cs and all the medications and all the good diabetes care that we're supposed to give. So that's the simplified version. The more complex version is that if the patient has less than 80 and the BMI is less than 30, you decrease by 4 units, and that's true regardless of the BMI. If the glucoses are between 80 and 99, you decrease by 2 units in both situations. No change if you're between 100 and 140. If you're between 140 and 160 and your BMI is less than 30, you increase by 1 unit. But if your BMI is greater than 30, you increase by 2 units. If you're between 160 and 200, you increase by 2 units and 4 units respectively, and over 200, 3 units and 6 units. And again, every 3 months you check all the things I mentioned. Now, that seems complicated, so I'm going to give you an alternative that's, to my mind, simpler. But I just told you what the official protocol is for the county. we would start with 16 units of either NPH, glargine, or detamere, and that's about what the county would start with, in overweight and obese patients, and 10 units in lean patients. We use the 88 target, which is 70 to 130. And if, again, like the county, if 50% of the values are over the target, then we would increase by 4 units in overweight or obese patients, or 2 units in lean patients, or 10% of whatever dose the patient was on, whichever is greater. So if you're on 80 units and you're going to go up by 4, that's not a big enough change. We would go up by 8. But just think about, though, how long this is going to take. We're starting with 16 units or 15 units, and many of our obese patients are on doses that are 60, 70, 80 units. And I didn't mention it, but we're supposed to see these patients every 2 weeks according to the county protocol. And so if you're going up from 16 to 60 units, that's 44 changes, and that's every 2 weeks. It's 22 weeks. It's going to take a long time to get up there. So an alternative, and this is something that many patients can do, is for them to self-titrate. So, for instance, if they're taking NPH insulin at night, or bedtime with glargine or detamere insulin, and every morning that the before breakfast glucose is greater than the target, in our case 130, we would have them increase the insulin dose that evening by 1 unit if the patient were lean, or by 2 units if they were overweight or obese. Now, some patients are on 2 shots of NPH, so you've got to make sure that you're only talking about the evening shot if you're going to do self-titration. If the morning glucoses are less than 70, that evening you would decrease in lean patients the dose by 1 unit, and if they were overweight or obese, you would decrease it by 2 units. Again, the same caveat about the morning NPH. And if there's been no changes in the insulin dose for 1 week, then don't have them self-titrate. Have them come in and you do the titration over a longer pattern of time. If some patients are on glargine or levemir, long-acting insulin before breakfast, if the before breakfast glucose that day is greater than 130, then they would increase that dose that morning by 1 unit if they were lean, or by 2 units if they were overweight or obese. If that glucose value were less than 70 that morning, then they would decrease it by 1 unit if lean and 2 units if obese. And again, if there had been no changes in insulin dose for a week, then they would stop changing it and you would take over. And finally, some patients are on glargine or levemir twice a day. And so if that morning dose is greater than 130 in our hands, we would increase both that morning dose and that before bedtime dose by 1 unit each if lean, or by 2 units each time if overweight. Again, if it's less than 70, you would decrease both that morning dose by 1 unit in lean patients, and before bedtime by 1 unit in lean patients, or 2 units if the patients were overweight or obese. Again, no changes for a week, then you would take over. So in that way, you can get to target much faster than if we see these patients every 2 weeks, if we can even see them that rapidly. Otherwise, it takes a long time to get them up there. So those are the 3 county protocols that were officially agreed upon by the committee, and where I was asked to bring to your attention. So I thank you. I can mention that if you're interested, these slides are available on the CDU website at the address that's just at the bottom of the slide. And I'll open it for questions.
Thank you, Dr. Davidson, a great talk. And we're also going to post the webinar probably on YouTube, the county YouTube, but also probably on the Drew website. What I'm going to do is we're going to have the chat function available. So, so people can ask by the chat. We have several questions about adjusting your camera. Sorry about that. The cost, so John asked, so anybody, please send on the chat function your questions. John from Harbor asked, the cost of BTB4 is about $10 per day. for something for 0.6% in 1 year and a 0.3% at 4 years. Is it worth it?
Well, in the head-to-head trials, you get almost as much of an effect with the DPP-4s as you do with the sulfonylureas. Now, the county has to pay the difference, whatever the plan charges, the county has to pay the DPP-4. And so the question you're asking is it the extra cost to the county worth doing it compared to the hypoglycemia and the weight loss and the weight gain? I would tend to agree with you that sulfonylurea is a better choice, but you can get around those two side effects by the DPP-4 if the county has to pay for it if the plan will cover it.
I'll answer that also. As Dr. Davidson sort of maybe the next part of this will be, what do you do if somebody's on BIDO, for example, and is uncontrolled, or again, somebody's on oral, they're still a little above the goal, they're on the metformin, sulfonylurea, and glitazone, and let's say your goal you want a 7 for them, and they're at 7.5. You don't really want to go to insulin yet, so that might be a time to add a DPP-4 inhibitor to go from the 7.5 to the 7. Okay. The next question is from Natalie. We'll get back to John's question if we get some other ones. What is the maximal dose of Lantus daily, and when is it advisable to switch to BID? Great question.
Good question. The maximal dose is the one that does the job. The absorption of insulin is delayed and erratic the more volume that's in there. So what I do is if they get to 80, once we go above 80, I split it in half. And I use the same dose before bed and before breakfast. I don't understand the reasoning between using a different dose at one time the other time, since it's a peakless insulin, and it's only a matter of how long it lasts. It doesn't peak to make, in my mind, to make it any sense to have two separate doses.
So I think the question she's also asking is, when do you go to twice a day? So I think
the answer is if you get to over 80 units, is when I usually split it.
And then what would you do? Would you go to 45 and 45, or how would you?
Oh yeah, you split it. So
you go up a little bit.
Yeah. So say you're at 80, then you go to and if you're going up by 10%, so you go to 88, so you get 44.
And I think a related question that maybe Dr. Davidson can comment on also is, when you're on BIDO, you're on nighttime NPH insulin. When would you go to the next step, and what would that next step be?
All right, so this is outside the county protocol, but I'll be glad to answer the question. Once you get your fasting glucose in target, and 3 months later, your A1C, in our hands, we use 7.5%. If it's above 7.5% and you're at target fasting, then we go on to intensification. If you suspect that you're going to really probably have to do that, once you get a target and you don't want to wait 3 months, you can do a before dinner glucoses, and if they're high, 180, 200, you know that the glucoses during the day are too high, and you could then go on to an intensified insulin regimen before 3 months.
Catherine asks, will you please explain why the DPP-4 is to be stopped if adding an insulin when the patient is on oral meds in the daytime?
That was one of the wisdoms of the committee that I could not necessarily understand either. But I think if you're on sulfonylurea and a DPP-4, they both cause insulin secretion, increased insulin secretion, and the committee felt that why give two agents that increase insulin secretion? So if you're not on a sulfonylurea, you would continue a DPP-4. You have one of them that increases insulin secretion, and they felt that you shouldn't be on both of them. You may have an additional effect, or you may not.
Okay. John asks, why not have a target of 100 to 120? Beta cells can wake up at 110. BIDO 100 to 140 is a bit high, in my opinion.
I personally, if to get better control, 100 to 120 would be better. The thought of the committee was you're more likely to get hypoglycemia that way, and so the consensus was 100 to 140. And as you heard, we use 70 to 130. The targets for all of the studies have used 100 to 120, and there's been more hypoglycemia with those targets. So the bottom line of the answer is, the higher your target, the less likely you are to get hypoglycemia, so you have to strike a balance between good control and risk of getting hypoglycemia.
SF asks, what do you do with an 82-year-old lady who refuses to take metformin because of severe side effects, and your A1C is 7.2? I did want to add one other thing that Dr. Davidson went over briefly in his protocol, but might have been missed, is there's also metformin extended release on county formulary that often has less GI side effects than the regular metformin. So that is an option on patients that are having side effects, GI side effects. I'll let Dr. Davidson answer this question.
I think that is in there, and I just forgot.
Yeah, it was there, but you went really fast already, right?
Yeah, apologies.
You want to answer this question?
What's the question?
What do you do with an 82-year-old lady who refuses to take metformin because of severe side effects, and her A1C is 7.2?
I congratulate her having an A1C of 7.2. In other words,
lifestyle changes, maybe?
She's lived to 82, whatever lifestyle she has, I don't know if you're going to make much of a difference. I think what I'm saying is that according to changing your A1C target, she certainly would fit into limited life expectancy, and I would just keep her where she is.
Any advice when we switch from Lantus to Levemir, i.e. any adjustment?
No, we switch unit to unit. The only potential, quote, adjustment, unquote, is that Levemir doesn't last as long, and sometimes you have to give that one twice a day, just because if you give it, well, we usually have to get the high doses with it, and therefore that's why you split it. But the bottom line of the answer is that we use a unit-to-unit substitution.
SF asked again, I think on our 82-year-old lady with having medicines, I think your answer was no medicines will be needed. Is that correct, Dr. Davidson?
That's correct.
Do we have any questions from the people in the room here? Kazi, go ahead.
Yes. My question is that do patients get to know or are they being informed they change the protocol? Is that necessary? I mean, does it come to at all when things like this happen?
So the question is, do patients get informed of the changes in protocol? Only to the extent that physicians discuss whatever treatment they're going to use. They're not told specifically that the county protocol says you do A, B, and C, because the physicians always have clinical judgment to use, and they don't have to follow protocols.
I think when a new medicine becomes available, we do discuss that with the patient as an option. I did submit, on behalf of our committee, a request for an SGLT2 inhibitor to come on formulary. I think it is going to revolutionize how we treat our patients here with the drug that gives you excellent glycemic control, doesn't give you hypoglycemia, gives you some weight loss, controls your blood pressure, and it's a pill that's pretty easy to take with minimal side effects. So I'm really hoping that gets on county formulary, and then when our patients come in, we will discuss that as an option with them.
I have a question. In the obese patients, you bump the insulin form. If they got hypoglycemia, then you can wean patients. I understand why.
Want to repeat your question?
Yeah, repeat the question. It's a fair question. In the obese patient, I suggest we drop the insulin dose more if the patient's hypoglycemic than in a lean patient of 2, and it's hypoglycemia. I guess the reason is that they're insulin resistant, and therefore a smaller change would be less likely to have an effect in an obese patient. I've never been asked that question before, but that's the best I can come up with. So that a 2-unit change in their whole balance would be much less of a change for them than a 4-unit change.
Any other questions? Okay, I thank Dr. Davidson for a great talk, and thanks everyone for joining us both live and by webinar. Thank you, everybody. There.